Welcome back to the series of lectures in rheumatology. So we'll be starting off with a very interesting and very complex topic, which is vasculitis. So vasculitis we'll be discussing in various parts. So in the first part of the lecture, we'll be looking at approach to vasculitis, classification, and predominantly we'll be discussing large vessel vasculitis. Okay, so let us understand the basics clearly and then you will understand the patterned approach to vasculitis, which makes it much easier. So let's begin. So what exactly is vasculitis? Vasculitis refers to the inflammation. It refers to the inflammation of the vessels. Okay. So it refers to the inflammation of the vessels. Itis means inflammation. So due to autoimmune conditions, due to an underlying autoimmune process, there can be inflammation of the vessels, and this is what we call as vasculitis. So if you just look at the histopathology of a vessel, it comprises of multiple layers, right? So you have an artery, you have a vein, you have arterioles, venules, and when you look at it in the cross section, what are the layers that you can find? So the outermost layer is called as the tunica adventitia. Then the middle layer is called as the tunica media. And the innermost layer is what we call as the tunica intima. Right? And then we have an external elastic lamina. And we have an internal elastic lamina. Okay. So why should we be knowing about the different layers and the structure or the histopathology of the vessels in detail? This is because once we understand the pathology, we can understand why certain clinical features are seen in different types of vasculitis and how each of these syndromes have different clinical manifestations. Alright, so there are three layers: tunica adventitia, media and intima, and we have an external elastic lamina and an internal elastic lamina. So whenever there is an underlying autoimmune pathology and there is inflammation of the vessel, so what happens? So what happens is that you can see that there is infiltration of what? There is infiltration of your inflammatory cells, which can be predominantly neutrophils or lymphocytes, most often neutrophils, which infiltrate into the vessel wall and cause lot of inflammation. The ongoing inflammation can cause destruction of a single or multiple layers of the vessels, right? So there is destruction of a single or multiple layer of the vessels and finally resulting in occlusion of the artery, occlusion of the vessels, which you can see here, right? So the entire lumen is occluded. Okay, so this is how vasculitis appears. So there is an inflammation of the vessels, there is infiltration of the vessel wall by mononuclear cells, by neutrophils, by lymphocytes, ultimately resulting in occlusion of the vessel. And there is damage to one or more layers of the vessel wall as well, right? So this is what happens in vasculitis. Now what is vasculopathy? So we have to understand the basic difference between vasculitis versus vasculopathy. So vasculopathy is also seen in autoimmune disorders, where the underlying process is slightly different, where there is a complete occlusion of the vessel due to what? Due to endothelial damage. There is occlusion of the vessel due to endothelial damage. So there is endothelial damage due to some underlying process resulting in thrombosis. So there is a thrombus formation which results in occlusion of the vessel. So if you see the vessel wall, there is a thrombus formation which occludes the vessel, and this is what we call as vasculopathy. So the most common condition where you find vasculopathy is seen in systemic sclerosis. Okay, so we understand that vasculitis results in inflammation of the vessel wall, whereas vasculopathy occurs due to endothelial damage resulting in thrombosis of the vessels. So ultimately both vasculitis and vasculopathy results in compromise of the blood flow to internal organs as well as the skin. So it may result in ulcers, it may result in purpura, it can result in multiple organ damage. but the basic pathogenic mechanism can be different, and this is how it is different. Okay, so this is the major difference between vasculitis and vasculopathy. Fine. So let us understand a little bit more in detail about the different patterns and your pathophysiological processes in different types of vasculitis. So first, there can be a pattern where if you do a biopsy, you find fragmentation of the internal elastic lamina, right? So this is your structure of the vessel which is there inside. So we have just now discussed that there is an internal elastic lamina which is present here. So the internal elastic lamina alone can get fragmented because of inflammation. Okay, and this is where what is seen in which condition? It is predominantly seen in your giant cell arteritis. Giant cell arteritis. Okay, so remember, if you are given an image or if you are asked for a spotter question, fragmentation of the internal elastic lamina is seen where? It is seen in giant cell arteritis. Okay, then the next term that you should be aware of is what is necrotizing vasculitis. Okay, what is necrotizing vasculitis? So in certain types of vasculitis, you can have necrosis of the vessel wall. You can have necrosis of the vessel wall. And what type of necrosis do you see? So if this is your vessel, what is present within the vessel? You find RBCs, correct? But with this necrotizing vasculitis, you may find that the RBCs are getting extravasated outside. Okay, so the RBCs get extravasated and there is a complete necrosis of the vessel wall. There is a complete necrosis of the vessel wall, and this is what we call as fibrinoid necrosis. Fibrinoid necrosis. This is what we call as fibrinoid necrosis. Okay, fine. And this fibrinoid necrosis is predominantly neutrophilic. It is predominantly neutrophilic in nature. The most important cell which is involved in the mediation of the inflammation here is neutrophil. Okay, so there is complete necrosis of the vessel wall with extravasation of the RBCs. This is what we call as fibrinoid necrosis. And this fibrinoid necrosis is seen in what type of vasculitis? Predominantly your small vessel vasculitis. Predominantly your small vessel vasculitis. What are they? They include your vaginous granulomatosis, which is now called as granulomatosis with polyangiitis, microscopic polyangiitis, and EGPA, eosinophilic granulomatosis with polyangiitis, and necrotizing vasculitis can also be seen in polyarteritis nodosa. Okay, so this is what we mean by necrotizing vasculitis, fibrinoid necrosis. Then, what is the next term you should be aware of? Where do you see granulomatous vasculitis? Granulomatous vasculitis means you find the evidence of granulomas when you do a biopsy of the vessel. Okay, so what are the granulomatous vasculitis you should be knowing? They include your large vessel vasculitis such as GCA and Takayasu arteritis, and amongst the small vessel vasculitis, remember, granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis. So the granulomatous vasculitis include GCA, TAC or Takayasu arteritis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. Clear? Okay. Then the next term that you should be aware of is something called as leukocytoclastic vasculitis. So what is the meaning of leukocytoclasis? Leukocytoclastic vasculitis means that, again, this is a type of vasculitis where there is inflammation of the vessel wall. Yes, so you do find inflammation of the vessel wall. But what is the odd feature here? The predominant cells here are again neutrophils, but the vasculitis occurs because the neutrophils themselves break down. Okay, so there is a leukocytoclasis. So leukocytoclasis is seen. The neutrophils themselves break down and there is an abnormal netosis, right? So there is formation of neutrophilic extracellular traps, what is we call as the NET. So abnormal netosis and neutrophil breakdown is leukocytoclastic vasculitis. And where do you see this? You see it again in the small vessel vasculitis. But which type of small vessel vasculitis? It is the immune complex mediated small vessel vasculitis. Immune complex mediated small vessel vasculitis is where you see your leukocytoclastic vasculitis. Okay. So necrotizing vasculitis is predominantly seen in which type of small vessel vasculitis? ANCA associated small vessel vasculitis and your polyarteritis nodosa. Immune complex mediated small vessel vasculitis is characterized by leukocytoclastic vasculitis. Okay. So these terms are slightly important so that you don't get confused and you understand the patterned approach to vasculitis. Okay. So fragmentation of the internal elastic lamina is seen in giant cell arteritis. We have understood what is fibrinoid necrosis and where it is seen. Granulomatous vasculitis, remember GCA, Takayasu, GPA, EGPA. Leukocytoclastic vasculitis is seen in immune complex mediated small vessel vasculitis. Clear? Fine? We are clear till here. Now, before we understand what are all the different types of vasculitis, we should know the classification of vasculitis, which is called as the revised Chapel-Hill classification. Revised Chapel-Hill classification classifies vasculitis based on the diameter or the vessel size that is involved. So it is classified as large vessel vasculitis, medium vessel vasculitis and small vessel vasculitis. Okay. So it is classified as large, medium and small vessel vasculitis. So what do you mean by the large vessels? So aorta and the branches are called as large vessel vasculitis, whereas the visceral arteries, which includes your GI arteries like your mesenteric arteries, these are part of the medium vessel vasculitis. Arteries of the lower limb, arteries of the upper limb, all of these are medium vessel vasculitis. And the small vessel vasculitis include what? The arteries break down into arterioles, venules and veins. So all these are part of your small vessel vasculitis. So revised Chapel-Hill criteria divides the vasculitis based on the artery size. Aorta and its branches, large vessel vasculitis. Medium vessel vasculitis, GI arteries, mesenteric arteries, small vessel vasculitis involves the arterioles, venules, veins. Okay, fine. Then also part of the classification are certain separate criteria which includes the variable vessel vasculitis. Then we have the single organ vasculitis, right? So we have the single organ vasculitis, right? So first let us understand the different examples for each of these. So which are the large vessel vasculitis which predominantly involve the aorta and branches? They include the giant cell arteritis and Takayasu arteritis. Giant cell arteritis and Takayasu arteritis are large vessel vasculitis. Then under medium vessel vasculitis, what do you have? You predominantly have polyarteritis nodosa and Kawasaki disease. Polyarteritis nodosa and Kawasaki disease are your medium vessel vasculitis. Small vessel vasculitis can be classified into two types as immune complex mediated and ANCA associated vasculitis. So immune complex mediated includes your anti-GBM, which is also called as good pasture disease, then Henoch-Schönlein purpura and cryoglobulinic vasculitis. ANCA associated vasculitis, we mainly have GPA, granulomatosis with polyangiitis, NPA, which is microscopic polyangiitis, and EGPA, which is eosinophilic granulomatosis with polyangiitis. Okay, so this is your revised Chapel-Hill classification for vasculitis. Large, medium, small. Small is classified as immune complex mediated and ANCA associated. Then what is a variable vessel vasculitis? It can involve both the large and medium vessels. Example is your Behçet's disease and Cogan's syndrome. Behçet's disease and Cogan's syndrome. Then separately we have another group which is your single organ vasculitis, where only single organs are involved, like your primary CNS vasculitis, and cutaneous vasculitis. Cutaneous leukocytoclastic vasculitis is an example of single organ vasculitis. Apart from that, these are all the primary vasculitis syndrome. We also have secondary vasculitic syndromes, vasculitis secondary to underlying connective tissue disorders like SLE or RA. So they are classified separately. Then drugs that cause vasculitis. Drugs can be associated with ANCA or immune complex mediated like propylthiouracil, hydralazine, penicillins and sulfa drugs. This is drug-induced vasculitis. Infections which can cause vasculitis include syphilis, right? You have endarteritis which happens in syphilis, so that can cause vasculitis. Tuberculosis can cause vasculitis. Rickettsial diseases can cause vasculitis. And malignancies like lymphomas, renal cell cancer, CA bladder, all of these can cause vasculitis. So in one slide, we have summarized what is your revised Chapel-Hill classification. Okay, so Chapel-Hill classification classifies based on the size of the arteries as large vessel, medium, small vessel. Small vessel is further classified as immune complex mediated and ANCA associated. Then you have your variable vessel, single organ vasculitis and secondary forms of vasculitis. These names may seem a little confusing, but we will be dealing with each of these in detail and you will understand it a bit better. Clear? So this is about basically how you approach your vasculitis, right? Now let us move on to the first category, which is your large vessel vasculitis, and we will be looking at the clinical patterns in detail. So what are the prototype diseases under the large vessel vasculitis? This includes your giant cell arteritis and Takayasu arteritis. Okay, so giant cell and Takayasu arteritis are the prototype diseases that we will be learning about. What are the vessels that are involved? Since this is a large vessel vasculitis, it predominantly involves aorta and branches. Okay, aorta and branches. Okay, so whenever you have a large vessel vasculitis, what are the common clinical features? So this helps you understand what is the pattern with which the patient is going to present to you. So remember, there will be asymmetrical pulses. Person in having a vasculitis involving the aorta and the branches will have asymmetrical pulses. So if you measure the blood pressure on one hand, it may not be recordable, and in the other hand, it may be recordable. So you find asymmetrical pulses. Then there can be history of limb claudication. Okay, there can be history of claudicatory pain, right? So if you recollect from your classes in surgery, claudicatory pain means whenever there is a compromise to the blood flow, right? So that is always not atherosclerotic. It can be a vasculitis as well. There can be dilatation of aorta and presence of bruits, vascular bruits, because this vasculitis in the ultimately is going to cause stenosis and it is going to cause a decrease or absence in flow. Okay, so asymmetrical pulses, limb claudication, dilatation of the aorta, presence of bruits, all of these point out towards a large vessel vasculitis. Okay, large vessel vasculitis. Clear? Fine. So let us move on to the first of the prototype diseases, which is giant cell arteritis. Okay, what are the other names? This is also called as temporal arteritis. Temporal arteritis. It is also called as Horton's disease. It is also called as Horton's disease. Right? So when you look at the pathological basis, there is transmural inflammation. There is transmural inflammation and the predominant cells are lymphocytic. The predominant cells are lymphocytic. They are lymphocytes. They are lymphocytes or macrophages. And what do you find? The key feature is fragmentation. There is fragmentation of the internal elastic lamina and the cells are lymphocytic. Remember the other types of vasculitis that we had learned, necrotizing vasculitis, fibrinoid necrosis, leukocytoplasis, all of these the cells are neutrophilic Here it is predominantly lymphocytic and there is fragmentation of the internal elastic lamina, right? And another important feature is the presence of this granuloma. We had just learned that under the granulomatous vasculitis, GCA is one of it. Okay, so giant cell arteritis, these are the key important histological features of GCA. GCA is also called as temporal arteritis and it is a large vessel vasculitis. Fine. So what are the vessels that are involved? As the name suggests, the most common is your superficial temporal artery. Okay. So the most common artery that is involved is your superficial temporal artery. Apart from that, other aortic branches can also be involved. The intracranial vessels are usually spared. It predominantly involves the extracranial arteries, but in rare cases, if there is an intracranial GCA, then it can result in strokes. Okay. So in rare cases, if there is an intracranial GCA, it can result in strokes. So the most common artery that is involved is superficial temporal artery. Okay. Giant cell arteritis, remember always when compared to its counterpart Takayasu arteritis, giant cell arteritis is a disease of elderly. Okay, it has a mean age of diagnosis of about 70 years. Okay, so it's predominantly a disease of elderly and it affects elderly females. So it affects females more than males in a ratio of 2:1. So this is predominantly a disease of elderly. Fine. And before we move on to the clinical features, a very important characteristic feature that you have to remember is the syndrome that we call as PMR. PMR is Polymyalgia Rheumatica syndrome. So this is an important syndrome which is associated with giant cell arteritis, which is characterized by predominantly proximal muscle pains, predominantly your shoulder and girdle, hip girdle pains along with elevated ESR. So for a long time, giant cell arteritis may not be detected. It may not present with your characteristic feature of headache in an elderly patient. Rather, it may present with your polymyalgia rheumatica syndrome characterized by proximal shoulder and girdle pains along with a prominent ESR elevation. So this can happen for a long time before the headaches appear, or it may overlap with the headaches. So always keep in mind the underlying feature of a patient presenting with predominantly girdle pains may be a polymyalgia rheumatica associated with giant cell arteritis. Okay. So what are the associations of giant cell arteritis? So giant cell arteritis is associated with certain risk factors like smoking, varicella zoster virus or HLA-DRB 104. Okay, fine. So let us look at the clinical features of giant cell arteritis one by one. So the most important clinical feature is the presence of a headache. The headache is usually a unilateral throbbing type of headache. So always remember new onset headache in an elderly individual. Just now we have learnt that GCA is a disease of the elderly. So new onset headache in an elderly always considered to be as a red flag sign, and you always have to think of evaluating for giant cell arteritis, right? So this is characterized by a unilateral throbbing severe headache. Then very importantly, it can be associated with visual disturbances, right? What kind of visual disturbances? You have something called as altitudinal hemianopia. Okay, altitudinal hemianopia, predominantly it can also, if it progresses, it can result in AION, which is anterior ischemic optic neuropathy, which is demonstrated by this image here. So you can have vasculitis of the retinal arteries as well. You can have anterior ischemic optic neuropathy. So initial stages you have altitudinal hemianopia. In the later stages it can result in blindness as well. The third most important feature you have to remember is it can be associated with jaw claudication. It can be associated with jaw claudication. Jaw claudication refers to pain, especially by chewing. And constitutional symptoms may also be present, especially in the form of fever, weight loss, myalgias, and polyarthralgias can be present. So remember, new onset headache in an elderly, jaw claudication, blindness because of AION, all of these are characteristic features of giant cell arteritis. And when you examine the patient, you may find a thickened non-pulsatile, superficial temporal artery. Thickened non-pulsatile superficial temporal artery may be found on examination. Okay, so these are about the most important clinical features for giant cell arteritis. And don't forget ever about your polymyalgia rheumatica, which may be seen overlapping or preceding your giant cell arteritis, with symptoms of predominantly pain involving the proximal shoulder and proximal girdle regions. Okay, clear? Right. So how do we diagnose? So diagnosis should always have a high index of suspicion, especially in an elderly with new onset headache, and you find persistently elevated inflammatory markers including a raised ESR and a raised CRP. So when you do an ultrasound Doppler, a characteristic sign that you can find is called as the halo sign. So can you see here that there is a characteristic hypoechoic lesion or a hypoechoic region present when you do a Doppler over the superficial temporal artery, and this characteristic hypoechoicity is predominantly due to edema of the vessel wall, which can be demonstrated in the USD Doppler of the temporal arteries. The investigation of choice is a biopsy from the superficial temporal artery, right? But always remember that you may have negative results even in the biopsy of a superficial temporal artery, because there can be skip lesions. So you may miss out the lesion, and hence a longer length of more than 5 centimeters of the biopsy has to be taken and sent for biopsy. Okay, fine. So histopathological evidence would be the final investigation of choice, right? Okay. So what is the treatment for giant cell arteritis? So any patient in whom you are suspecting giant cell arteritis, always be proactive in its treatment, and the treatment of choice is systemic steroids. The treatment of choice is systemic steroids. So systemic steroids is the treatment of choice in giant cell arteritis. Also, giant cell arteritis is predominantly mediated by interleukin 6, and second line drugs would be Tocilizumab. Tocilizumab would be the second line in this treatment of choice for giant cell arteritis. Okay, so just to put things back into perspective, we are learning giant cell arteritis, which is one of the prototypes for your large vessel vasculitis. So we have learned that they present as polymyalgia rheumatica, they present as a red flag sign, which is headache in the elderly. It can result in blindness because of AION. It can result in jaw claudication. The investigation, remember, halo sign, and always remember, if you're taking a biopsy, it has to be of a longer length because there can be skip lesions and you may miss out. Treatment is steroids and Tocilizumab. Okay, clear? So this is about giant cell arteritis. Now let us move on to the next prototype of the large vessel vasculitis, which is Takayasu arteritis. So Takayasu arteritis is also called as pulseless syndrome or aortic arch syndrome. Okay. So Takayasu arteritis in fact is the most common cause of large vessel vasculitis in India. Okay. So Takayasu arteritis is actually under-recognized, but it is one of the most common causes for large vessel vasculitis in India. And Takayasu arteritis is a disease of the young, and it is more common in females than in males. Okay, it is a disease of the young when compared to giant cell arteritis, which is a disease of the elderly. and associations include HLA-B52, HLA-B67. Okay, fine. So, what are the most common vessels that are involved? Unlike your giant cell arteritis where superficial temporal artery is most commonly involved, here subclavian artery, aorta, renal artery, pulmonary involvement, coronary involvement, all of this is present, of which you have to remember subclavian artery is the most common artery that is involved. Okay, fine. So, what are the symptoms with which your Takayasu arteritis is going to present with? Takayasu arteritis is going to present with symptoms of asymmetrical pulses, asymmetrical blood pressure, and that's why it is also called as the pulseless disease. And since this vasculitis involves the subclavian and its branches and predominant renal artery involvement, it can be associated with renal artery stenosis resulting in hypertension in the young. Okay, so this is the most common presentation, hypertension in a young individual because of renal artery stenosis, and when you examine the patient there will be asymmetry in the pulses. This is the most common presentation. Okay, unlike your giant cell arteritis, constitutional symptoms are rare. Okay, so the first difference that we found is that Takayasu is a disease of the young and constitutional symptoms are rare. Most common artery that is involved is subclavian artery. Okay, and amongst the other symptoms, you also have the other symptoms. Okay, so if the patient develops any symptoms, the most common symptom will be a claudication. It can be an upper limb claudication, it can be a lower limb claudication, but many a times, most often it is ignored. The presentation will be as hypertension in young. The symptom which will be is claudication pain. Okay, so this will be in the form of a claudication pain, right? So when you look at the signs, what will it be? The sign will be you will have hypertension in the young when you look at the blood pressure, and you can have asymmetrical blood pressure recordings, asymmetric BP recordings. In the renals, it can cause renal artery stenosis. In CVS, you can have aortic dilatation and you can have evidence of murmurs, and there will be asymmetrical pulses as well. Will you find a bruit? Yes, you may find a renal bruit because of renal artery stenosis. Okay, so this is how your Takayasu arteritis usually presents. So, what is the investigation of choice? So, the investigation of choice to diagnose a Takayasu arteritis would be an MR angiography. An MR angiography which will show the evidence of narrowing. Can you see narrowing in multiple places, in multiple arteries? It can also show evidence of renal artery stenosis. So, it can present with AKI, it can present with rapidly progressive renal failure because of bilateral renal artery stenosis, it can present as hypertension in young, it can present as hypertensive emergency as well. It may present with flash pulmonary edema because of renal artery stenosis, hypertensive emergency, hypertensive encephalopathy. So, all complications of hypertension can be there, right? The investigation of choice is an MR angiography where you see evidence of narrowing of the vessels. Okay, so what is the treatment? Again, the treatment is with systemic steroids. Treatment is with systemic steroids. Okay, so this is about your Takayasu arteritis. So with this, we have come to the end of our discussion on approach to vasculitis, and we have looked at two prototype diseases in large vessels which include your GCA and Takayasu arteritis. Thank you.